stress fractures of fibula after long fibular struts. They are they help you. They help you to develop more callus. So that's what I'm saying. If you go through microvascular surgery journals, all of them will show that fibula fracture has occurred and limb has consolidated, the construct consolidated. So this is considered to be a good thing and not bad thing. And as I said, otherwise you need anchorage. It may be little less than conventional plate, but you need anchorage. See, initially all locking plates came in with unicortical screws, thinking that you don't need stability, you don't need anchorage. All of them failed. That is why we have started with bicondylar, rather bicortical locking plates. Need some anchorage. So go, yes, please.
Ryan, did he complain of any knee pain while walking or while doing his activity?
Can you speak loud?
Did he complain any knee pain while walking or anything?
At the moment, no.
No knee pain.
At the moment. Maybe he'll need a joint little earlier than others. Agree, absolutely. But at least now we have a decent proximal fragment. By the time he reaches the stage where he needs a joint, this would be completely reformed, except the posterior, of course, shift, which was impossible to correct. So I take you back to this paper, 1990. And in fact, I'm going to stress more and more on this concept. This is 1990 paper published by Dr. Kothari after extensive experimental work, that bone is like air in a tubeless tire. It gives rigidity and shape to the tire. In return, it takes shape of the tire. It is independent. Now, it's a very controversial paper, but I'm sure you would, if you go back to your cases, you'll realize that it is very, very true. The last, fourth thing is very controversial. Nothing is attached to bone, tendon, ligament, articular cartilage, nothing is attached to bone. So, if you have a cavity, a clean, uninfected cavity, and have, most importantly, it fills casing or envelope provided by soft tissues around. So, if you give a good casing, bone will form. And it will take that shape. Not just it will form, it will take the shape of the casing. So if you create an envelope of appropriate size and shape, maintain its shape, and even if you add meniscal bone, it will form bone. Minimal quantity of bone. I'm not saying every time you do that. All I'm trying to say is, if you have a good cavity and if you support it, of course, it needs support, internal, external, bone graft, anything. But the shape has to be maintained. With minuscule quantity of bone, bone will form hypertrophy and take shape of that bone. So as I said, controversial, but I'm quite convinced about this. Anyway.
Any
Here.
Any questions from audience?
Yes, please. Can you use the mic?
Please tell.
See, as I said, I had kept all options open. I had kept all types of plates, everything. But it was the upper fragment, there was nothing. There was nothing. It was only a shell of bone. Laterally, there was practically not even a shell. Medially, I tried to put a plate. We put a screw inside. There was no bone to hold it. There was no bone to hold it. So maybe we could have thought of and orthodontics. I mean, we consider all those facilities, all those modalities. But orthodontics, I thought if we can get even say 30 degrees, 40 degrees, 50 degrees movement, we have already, now we have a 70-degree movement. Why not? Why not? I mean, it was a risk we took. We discussed at length with patient. Must have spent about 2 hours in discussing at various time with various people. And that time we said that we will go in with this. Maybe he'll need an orthodontist. Maybe he'll need something else.
So indeed, a healed, uninfected union is nothing better than that what you can give to a
Correct,
patient.
correct.
He should be ever grateful to this thing. But just for academic purpose, uh, now he is having 70, 60, 70-degree range of movement. That is very good and social to be at places like. Uh, this will come certainly with experiences for people who do such type of cases. Uh, but then eventually giving it a
Just 1 minute. I'm little hard of hearing, so if you can speak loudly.
Sir, um, I guess the end result was very gratifying. Had it been given a thought of fusion, maybe probably that would have corrected the subluxation, that would have corrected the infection, that would have corrected the shortening, and probably would have been less cumbersome to the less tedious mentally to the surgeon and the patient. Just a thought.
There are many ways to skin the cat. Many ways. There are various ways. The idea of presenting this is A, develop a clean, uninfected cavity. Your first and foremost and even last aim is to create a clean, uninfected cavity. Then you can do whatever you want. What fixation you do is not important. You do a very aggressive debridement, very aggressive, excise whatever infected, query infected, sclerotic bone in infected non-union, good flap cover, and then you can do whatever you want. There is no problem. I will not say that whatever I did was the only or best thing. You could have done a plate. I'm not saying no. But the first thing was the most important thing. Creating an uninfected cavity with a flap cover.
So,
Yes, please.
Please tell the name. Introduce yourself and then ask the question.
Sir, myself, Dr. Anil Dule, applying the same principles in the paper. The bone, the non-union side has been already debrided. So just sir, applying the ring, distracting the knee joint, and doing a distal corticotomy, and then transporting up. Will it help? That
It
because
could. It could, provided you have a decent proximal hold. Getting a proximal hold in tibia would have been difficult.
we are
So you could go above the joint. Try, absolutely possible. Everything, as I said, hardware is not important. Software is. I mean, we have been stressing on hardware again and again and again. What we are forgetting is biology. The idea of this controversial case was not to show that hardware is important, but not as important as biology. Okay.
So I think 15 minutes is less for Dr. Agashe sir to teach the infection. When I used at Hinduja with him, we used to say to the bugs, "Bhag ja bete, you are in Dr. Agashe sir's hand." So what we've learned from this case is stress, X-ray, still expule, excise all the scar, have plastic surgery backup, aim for good vascular thick cover or the non-union site, have your plan ABC ready on table, and it's a team work in a complex cases, and jam the canal with small pieces like a jigsaw puzzle. So with this, I would like to call Dr. Aditya Menon, very good friend of mine, consultant at Hinduja Hospital, orthopedic infection consultant. Dr. Aditya, over to you.
Dr. Abhishek. To this case, I would request, I think there are some PGs here. I want your active participation. There's no right or wrong. I think from the first case, you realize that no orthopedic surgeons will agree with each other. We'll all keep arguing and fighting, but ultimately, we want the best outcome. So please be active. Give your opinions. Right or wrong doesn't matter here. And before I go ahead, even in the previous case, as a team, we felt that arthrodesis is a very, very good option in this case because salvaging this would be more of a challenge surgically. But the patient and his father was very, very keen on having some mobility. They said कि सर 20 डिग्री आएगा तो भी चलेगा लेकिन पाँव सीधा करके मत छोड़ो जिंदगी भर के लिए. So that was the idea, to give him some movement, and ultimately he'll require a joint replacement at some stage to delay that joint replacement and hope for the best. That was how he went ahead. So coming on to this case, I hope I'm audible. Yeah. This was an infection following a short PFM nailing. So this is a 76-year-old gentleman presented to us 2 years after a nail done for a right IT fracture. He was operated elsewhere, united well. There were some circlage wires as well. He was hypertensive, non-diabetic. Nailing was done, and he had pain and swelling 2 months before coming to us. That was almost a year and a half, 2 years after the primary surgery. He was uneventful till then. Discharging sinus for a month, had taken a lot of antibiotics, but the infection continued. This was the clinical picture, scar with a sinus, and the X-ray showed a nail inside. So at this stage, I would want to open this out for a discussion. These are the options. As the patients ask us in the OPD, क्या करेंगे? Antibiotic, do we continue the antibiotic intravenous? Or we just do a soft tissue dissection, remove that sinus, scrape that sinus, close him, because doing an implant removal with either, whether nail or circlage in this case, with a 2-year-old fracture with so much bone is going to be challenging. So opinions from the delegates, from the senior faculty. Option C. So that's one option that we've got, remove the nail. The labs were, WBC was normal, ESR was, okay, so just go in, do a standard implant removal and leave the sinus. Okay, so that's option E. So option E is we remove the nail and put an antibiotic. If we find that there is medullary pus, we put an antibiotic rod inside. So here CRP was 20, CRP was elevated, ESR was elevated, but WBC was normal. He had not severe pain, he would get pain on and off. So it started with pain. The minute he had a discharging sinus, the pain settled. It would close for a few days.
So
Option C.
my option is option D. Because we have to, wires can be act as a source of infection, so I have to remove the wires also. After that, I have to do the material for culture sensitivity, and according to culture sensitivity, you have to give the antibiotic for minimum 6 weeks.
Absolutely.
This will be the radical for that patient, as the fracture is already united. Why to keep that implant as a source of infection?
Correct. So
If I can,
what is sir is
if I
suggesting
can
is
ask
we
you.
remove the nail, remove the wires, send for cultures, start targeted antibiotics. So what about the, so we went ahead, we'll go ahead with this, we did a flappy lateral position. Now, sorry, 1 second. Sorry, I think one slide is missing here.
So Aditya, if I can ask you a question.
Yeah.
Yeah. So that type of exuberant granulation at one point, would you infer something on that?
Would I infer?
Would you infer something on that present?
That florid infection would suggest that there is something going on inside. It is not just a subcutaneous infection. Ultimately, the sinus would be coming from somewhere within the medullary canal and the implant, since this is an implant inside. So the sinus itself happens over a period of time. It just doesn't happen overnight. So it suggests that there is a medullary infection and we must preempt that medullary infection and plan ahead. Yes, sir.
Do you think of doing a sinogram in this patient to know where the sinus is taking you?
Absolutely, sir. Absolutely. So sinogram is an extremely useful tool. It can be done with an X-ray or a CT or even an MRI sinogram, depending on what facility. We can inject the dye a day prior. That sinus tract will lead to wherever the source of infection is, and that gives us an idea about where the infection is. And I think previously a lot of surgeons, even now, use methylene blue to inject in the surgical dissection. So the minute we see methylene blue, we know that that is where the infection is. So I think we all agree that yes. We are seeing only the tip of the iceberg. What is actually there is deep inside. So following the sinus tract, excising the sinus tract is when we actually lead into the original site of infection. So this was the position given floppy lateral. You can see the incision, a long elliptical incision, excising the scar and the sinus. Now the idea is not to incise and not to go through the scar. Because what happens is the infection comes from within and the scar underneath of the scar is also infected. So you must go around the scars, make sure that whenever we are dissecting, we are reaching clean soft tissue. The minute we see the soft tissue which is being left behind is also infected, increase the width of the scar, especially in thigh. It's so supple that closure is generally not an issue. Make a wide incision, go wider if you feel that the surrounding tissue is also necrotic. But try and remove it in one big bulk like you would do for tumor surgeries. So we see tumor surgeons going in, they go through clean tissues, they go through clear margins. So this is abnormal, they would say maybe take 1.5 centimeters more. That is what we should do for infected cases as well. So you can see instruments holding both sides, going from either side, going deep up to the femur lateral. Like correctly suggested, the wires should also be removed. What happens to these circular wires is there's bone overgrowth on it, so it becomes extremely difficult. But spend some time, use a C-arm intraoperatively if you feel, chip out the bone using osteotomes, nibblers, cutters, find those wires and remove them. Because any wire can be a source of infection. Very difficult to know whether the infection is communicating with the wire or not. Assume that everything is infected at this stage. Try and remove all the implants if possible. And we achieved a good clean leg. So again, I would want to open it out for discussion. Is there anything else that we should do? We've removed the implant now. Yes, perfect. Intramedullary healing. Anything in detail about the intramedullary healing? What size?
So, how much you will read?
Do we keep a Siam ream only up to the tip of the nail?
No, the whole femur should be removed, sir.
The whole femur should be removed. Okay, perfect. That's the next perfect said. Anything else? Yes, absolutely. Local antibiotics. Maybe we can wait for a few days or put empirical to cover gram-positive, negative. When we ream, well, you correctly suggested we must ream the entire canal and more than the size of the nail. Where will the reaming material come? Absolutely, sir. Absolutely. That's the one take home apart from the other things in this case is make a distal window.
All the material will come out. There is no need to make a distal hole. Additional
Sir, Mike.
There is a chance of fracture. This is not that much. A big window is not necessary. You can just make a small vent. The just vent is for what? To prevent pulmonary embolism, not to drain out this. This window is going to be a problematic for the fracture. He may develop a.
Absolutely. So pathological
Don't
fracture.
give any.
second is already holes of nail is there. No entry point of the PFN is already there. It is a big one. If you see the size of the proximal part, it is around 11 to 12. You can pass a reamer through that easily and put a negative suction from that reamer. That's entry point only. We can remove all the medullary cavity material. Send that to the culture sensitivity, and depending upon the culture sensitivity, will take care of the infections.
We agree, we understand that distal hole is a big stress fracture. That is one stress to us also. What we realize is, although we have a screw hole at the distal locking site and the entry point, the infected material is actually a biofilm. It is not pus that will come out through a vented hole. One small screw hole will not let the biofilm come out because the medullary canal is completely covered with thick membrane. That is the source of infection. That thick membrane, even with suction, sometimes doesn't come out. It actually has to be grabbed and pulled out.
What the book says that you just create the raw area at that particular site to get a good circulation at that particular site for the penetration of the antibiotic. If you are doing a reaming with a bigger size, you are creating a raw area part for that particular biofilm area. So it will allow the blood to circulate there. It allowed the antibiotic to penetrate at that area. So it will take care of all the things. Instead of doing a distal or making a chances of pathological fracture in future, again that patient will come to you and trouble you. So instead of that, you can do a minimize things with a good result, I think.
I agree, but what you rightly said is once we ream, that area becomes raw. What about the tissue that has come off from that area and is going to stay distally?
That won't come out with the suction.
Suction ke saath, but it's thick tissue. We've tried all of that. It's so thick tissue, whatever comes out is just 20-30% of what is actually there. So it's thick. We've actually had a whole cup full, vati full of membrane which has come out from the window.
So the distal window tissue was sent separately for culture.
So we send the soft tissue pus from the screw holes as one sample, and the medullary reaming which is we actually use scoops, nibblers from the distal window to pull it out a second as a separate sample. Now whether it grows through different bacteria, that's irrelevant, but we send it as two separate samples. The message was, yes, pathological fracture is a big stress for us. I mean, as surgeons, we also don't want a patient has come with an infection for an implant root. We don't want him to have a pathological fracture. But we've had cases where we've not made the window and we've regretted. We've had a case of a distal ankle, septic ankle following a arthrodesis, where we didn't want to make a window. So there we had to ream from the calcaneum. We didn't want to make a window because it would create a stress fracture in the toxic. The reaming material went inside because it would obviously go inside. We use scoops to pull it out, but ultimately that causes
Dr. Dhule sir want to ask question.
Holding a long endoscope forceps. We can also use for this purpose instead of making
we
it
need 38, 36 size grabbers. We have them. If somebody can make it and we can actually visualize the room, everything fantastic. That is something I think we should. So revision hips. Yes. Yeah. So Karnak sir, I think already has that.
Yes.
I think those are things that we should get, but we have to ensure that we remove the entire tissue from inside. That was the message. Whether we use, yeah, and for osteomyelitis also we make bigger cavities. So we've made large windows, almost 22 centimeter size for osteomyelitis to be oval, not square, no sharp edges, and they consolidate over time. So stress fracture happens only if we keep sharp edges, square windows, and it's not oval enough. Otherwise, they do consolidate. Yes, they have to be non-weight bearing and partial weight bearing with support and avoid excessive torsional movements. Those are things that they have to be careful about. But the message here was whether we use long grabbers, whether we use a window, the medullary biofilm has to come out. We cannot leave it inside because that does cause secondary infection. And we had that in a few cases where we try to avoid a second infection. Please continue. not so popular distal window. Uh, like correctly suggested, we use the culture glue MSSA, use cefazolin, which is the first generation cephalosporin. That's all that is needed for MSSA, nothing major. For 2 weeks, followed by oral cephalosporin. Both are very reasonable and cheap antibiotics. That is all that is required for MSSA. Similarly, we use the cefuroxime. Now, this is a substitute that we use instead of antibiotic meal. The issue with antibiotic meal would be we have to go in and remove again. So, in cases where we don't want a revision surgery just for that spacer removal, similar weeks become a very, very good option. We'll discuss this during our antibiotic workshop as well. There are techniques of making sure that the similar weeks pass through the entire canal. We can use creamer handles, we can use exchange tubes and guide wires, and pass the weeks throughout the extent of the canal. So the spread of antibiotics is good enough. So this was at 12 months. Infection had settled. Now we started growing bone, even proximity. Even at this age, they grow bone. Even after implant removal, after everything is united, is degraded, the biology is so good that it starts consolidating where we make those holes, where we feel there'll be a chance of a stretch fracture. So the distal window with time also shrinks, especially 2-3 years now we had a long follow-up. We've seen the window never closes, but the bone consolidates, becomes thicker in the bone. The window size almost becomes one-third of what it was originally. About nail removal and surplus wire removal, we must attempt to remove all the implants, but make sure we do medullary healing and various options for removing the biofilm. But there's a biofilm inside, it's not just pus. Rather, if you have long grabbers and you're sure of cleaning it, or make an oval window distally, take care that the patient is non-weight bearing or partial weight bearing and give correct antibiotics. Bone formation still happens at this age. So I think I'll stop here in case there are any questions, or we'll go ahead to the.
Thank you, Aditya. Any questions from the audience? Okay. So with this, we move on to next presenter, Dr. Chandak sir. I would like to invite uh, a renowned orthopedic surgeon from Nagpur. He will present his case. From Aditya's case, what we have take home message is remember to excise all the scars, thoroughly rinse the canal, put the antibiotics bit throughout the canal, and keep your revision hip sets, longer scoops, longer disc forceps ready to debride thoroughly.
Good morning, everyone. Presenting an interesting case. Just a comment on the previous case about the windows. From the engineering principles, if you take a cylinder and the section in the cylinder is less than 1/10, it never loses the integrity of that cylinder. And as he said, the edges are smooth. It is not sharp edge, and it is one of the end of the bone. Very less chance of developing a pathological fracture unless a significant trauma happens. 94 by Kevin Pittsburgh, and who is the person who has classification of osteomyelitis common? Huh? Classification of osteomyelitis? Sarni Medal. He and Kevin Pittsburgh has published a paper on debridement in osteomyelitis. Please read that. Exceptionally good paper, and they say that up to 20% you can easily make a window. There is no problem at all. They have done CT scans and realized that up to 20% there is no problem at all. And please read that paper. So presenting this case, it was a well-healed fractured distal femur, had a floating knee injury in a 35 years old male, and he had flexion from 0 to 40 degree. As commonly happens in a floating knee injury, the knee movements are restricted, and most of these patients, being young, would desire a further knee flexion. That was his desire. The fractured tibia and femur healed. This was post of 3 years. No pain. He was working in a vehicle factory and wanted implant removal. Went to the first surgeon, the surgeon who operated him, and he wanted more flexion. So at this point of time, Any opinions whether implant removal at this point of time would lead to more flexion? As many times we may promise them 5 to 10 degrees may improve, or are there any other options to do that?
So
I would like
clinically, was there a bony block or it was just a
the clinical examination, as I saw him, was absolutely normal, non-painful, only 0 to 40 degree. The patella was mobile, but however, the quadriceps muscles, as externally seen, uh, were possibly shortened or stuck up to the femur. That was the presentation. No extra bony swelling, no extra obstructive thing in the joint per se. That was the clinical finding. So as it all looked healed, he was working normally. The first surgeon removed the implant. And these are the X-ray after implant removal. Being an insurance case, he took X-rays also post-operatively and allowed him around 6 weeks of rest. At that time, he went to his factory doctor who issued a certificate that he is fit to join duties. So even that had a medical, legal, clinical implication. When do we allow a person to join back duties? So he joined back. Any opinions here on this X-ray? Yes, absolutely. So there was a possibility of a stress fracture, and anything which could have prevented that. So at this, not to remove implant would be your choice. So assess complete union process is one. Okay. Never remove that implant. Yes, sir. A very good suggestion. Certain, yeah. A complex situation, multiple plates, orthogonal plates. It is a good suggestion to remove implant in stages that so that the bone matures further. I'd say it's a good suggestion. Yes, sir. You want it.
Sir, if at all you are surprised on table that we have done an implant removal and now you realize that there's some vent or window, there's some weak point that is left at that point of time in the bone. Whatever range of movement you could improve, that's a different part. But then at hand, uh, will you give it a thought that you can fill that void with a cement block over there? Just put some bone cement so that will augment that bone and the possibility of a stress fracture still reduces. What thought can you give to this?
So that is a possibility when you have a large void and you are required to remove implant for some other reason than union and just implant removal. It could be an implant removal for infection and then possibly you use the stimulant and beads so that that area is taken care of, but not in a situation where the bony union is possibly inadequate. I don't have in my own clinical experience any situation where I did it, but I may invite opinions on that. Yes.
Sir, one more.
Yeah, Agash sir is saying and then.
Yeah, my question, do you have a clinical picture? Is the scar totally adherent or was reasonably adherent to the plate?
Yeah, after this I will be just showing this card.
Because unless you have a good soft tissue cover,
The soft tissue was good.
soft tissue
Was very good.
the,
Very good.
the bone is extremely sclerotic.
Yes.
So I would definitely not try and remove the implant.
Yes.
That is one. Now that it has already occurred, if he comes to me at this stage, honestly, I don't think there is any way you can actually prevent it.
There is no
Prevent
way.
a pathological fracture. Possibly, I would put a plate again, but
Possibly.
I would avoid removal of implant with sclerotic bone.
Right. So very good point. Whenever there is a sclerotic union with a long segment of sclerotic union seen, implant removal should be very cautiously done or at least warn the patient. Yes, you were suggesting.
Sir,
Yes, please go.
or we can protect it with intramedullary titanium nails, flexible nails. So we can remove larger plates and can be protected with
So,
intramedullary
so if you
flexible elastic nails to prevent stress fracture.
if you go back to the union process,
Yes, it
the
is all sclerotic.
medullary
There is no
canal is
medullary.
sclerotic and there was no medullary canal as such. So that would have been quite a difficult thing.
So, was there any history of bisphosphonate used for healing or prolonged bisphosphonate?
No, no, he was just 32 years old.
So,
So
I mean, there is a tendency to still give bisphosphonates.
no, this patient never had bisphosphonate, never had bisphosphonate.
Yeah, I mean, we've seen cases
So,
where for union bisphosphonates have been attempted.
so bisphosphonate, I think, in a 32 years old male, a factory worker, I think, was not a possibility. Okay. Any other point? Yes, you were suggesting. Yeah. Yeah, go ahead, sir. This
The
we
problem
would
is that
value your
once
suggestion.
you open it out for removal of implant and you come under situation, the bone, you can see the cavity is there in front of you when you open it out. So that time you decide not to use the implant. The bone is sclerotic, so the biology has been totally gone. It is not like to grow any more bone. So in that case, whether you retain the implant and do bone grafting to cover up that area, just marginal sclerosis you have to remove and do a bone grafting, which is the biological and may give rise to a little bit better in like that. Whether it
And,
is possible.
and I would agree, good suggestion. And therefore, in our implant removal consent, we take a consent. We may not remove the implant if we find inadequate process of bone healing. That's a good suggestion, I think. So I'll go ahead with the case. So this was the implant removal was executed. He started working again, joined back, and during working got pain in the thigh. The tibia did not have any trouble. This was the X-ray after the implant removal. So this was tibia and this was femur, and suddenly developed pain, developed the stress fracture. So looking at this process of union for a distal femur, between a choice for a distal femur plate and an intramedullary implant, I think intramedullary implant scores because it gives you a zone of wider union. So that would be a choice retrospectively in this case. So the questions to the previous surgeon were, should he have not removed the implant and now what next? All investigations for infection were normal. Clinical examination, there was no nothing. He was otherwise hale and hearty except for this stress fracture. The bone metabolism also was normal as per normal calcium, phosphorus and alkaline phosphatase. CRP, ESR was also normal except for the small rise because of the fracture itself. So this is the now analyzing how it went ahead. This was the X-ray, a segmental fracture. You can see the long segment of bone, and there was some intercondylar element as well. The fracture was a simpler fracture. So was this a zone with a lot of avascularity? Was the question in mind? This was the lateral view. This is what the fixation was. The fixation is at this point of time 6 months. Assess the process of union in the X-ray. So this was the picture. This is at 1 year, patient walking, no pain. This was healing phase, uneventful except restriction of the range of motion. And I would agree with most of us thinking nowadays thinking that a fixation, a plate should have been longer, more flexible fixation, elastic fixation to give more callus. But that was what was done. Presentation to me, investigation all normal. Now what to do? How to manage this patient? One suggestion was reapply the plate, additional bone graft at the fracture zone. So any other suggestions? Yeah, please.
So I would like to take out that necrotic, the segmental, which was initially, which you thought it, and even I think of that, that is the avascular bone. So that has to be come out to have the good union, and then take a transport or a bone graft.
So taking out a avascular segment of bone if not infected, if not infected, would be your choice, because then you are removing a large segment of bone and then putting patient to a long period of rehabilitation. So
Yeah, because the pathological fracture is happened because of that hypertrophic vascular bone.
so there was no absolute infection, no granulation, nothing.
Okay.
So this was a stress fracture because he joined back duties at 6 weeks while working. He developed this fracture. So the history was very classical of a stress fracture in a zone which had a healing of a sclerotic bone. Please pass on the mic. आपको किसी को एक्टिव रहना होगा माइक देने के लिए.
For the intramedullary nailing with the bone graft. And second option we should keep as on the table that long plate with bone graft.
So a choice between a plate and intramedullary.
First choice will be the intramedullary nail.
Yeah. And the problem and difficulties were,
So if
as you can look at this zone, this,
so if I can add a point.
this was absolutely sclerotic, and here also totally blocked because of the fragment inside, an absolutely sclerotic bone. Yeah, please. You just make it on.
Open reduction at the fracture site, reaming, hold the femur upper end and lower end, and do an intermediate nailing with the refreshing the fracture site at the stretch fracture plus bone grafting would have been an option in this case as per my opinion.
Absolutely agreed. So you have to provide fixation. His suggestion is intramedullary nailing and bone grafting to achieve union. I accept totally.
So should we keep a
Proximal fragment and distal fragment to avoid any heterogenic complication during the surgery. If it is not possible, then you have to keep the long plate ready with the bone grafting.
Yes, agreed. So reaming a difficult canal, you have to develop those skills to to have a sharp reamer, somehow put a guide wire, and then ream it. I think that's a valid suggestion, and that was what was done in this case. So this was, see the result. This is the skin condition. The skin condition is quite normal. He had a long incision on the lateral side. Now, as it, this was a open nailing, open plate fixation initially. So this is the skin condition. Intraoperatively, so as was suggested, from the fracture site, we gradually created with a sharp reamer by hand, and then once the guide wire was passed, so we had to go in with inching guide wire technique. So a small guide wire being forwarded, then rim on it, then again forward because the guide wire was not passing as the whole medullary canal was blocked. So a gradual inching technique, and then that was managed with intramedullary nailing, bone grafting, as well as a derotation augmentation plate with unicortical screw, and that patient went uneventful. The lessons I learned in this case was, even after implant removal, ideally take X-rays. In a nowadays world, in previous era, we were never taking X-rays after implant removal. In nowadays world, because of all this litigation looming around our head, I always now take X-rays. Even after a Colles fracture, I have removed a plate. I would take a X-ray whenever it is removed. Number two, when they are joining back duties, on the footnote, you would give them certain precautions so that there are no litigations on that part in the factory doctor. Number three, sclerotic bone healing to prevent possibly the medullary flexible intramedullary splinting as a choice in difficult such cases is what the lessons I would have learned in this patient. Thank you very much.
Thank you. The tea and coffee is ready. You can have a tea coffee break. And next is Dr. Sun.
Yes, sir. No, no, no. This was a fresh fracture. This was a fresh fracture. Absolutely. Clinically, it was a fresh fracture. So could be, I think I must have done overdue But whenever there is a fractured distal and femur at the stomach zone, at the metaphyseal zone, near the metaphyseal zone, it is my standard policy to provide both intramedullary as well as extramedullary fixation as one stop go. And I do agree, if we would have given only intramedullary good fixation, it could have worked. It could have definitely worked. But from head and cavity, there are reports that out of 18 cases, still 2 went into non-union. So I think this is what I chose, but I would agree that yes, we can have an intramedullary.
Stability, especially in these cases and non-union cases. You will need absolute stability. You need to prevent even 1 degree of rotational movement, and you must have a plate that unicortical is adequate for prevention of rotation. But at least that has to be done.
One important advantage I notice always in these patients, they have no pain, they have a greater control on their knee power, and they mobilize to their fullest possible. In this case, we did a parapatellar release, and he developed more of around 25 to 30 degrees more of flexion. And they come down walking early without any support at 6 weeks. When they come down walking, we even forget that this was a patient of a non-union. So that strong is the fixation, is what my perspective is.
Nail and the rotation plate. So if we are going to put a plate, then this interlocking bolts they hardly they matter whether we put or don't put. The splintage is given by the nail, and derotation is provided by the plate. So that can be also done.
Yes.
Even in
Multiple options
Yes,
as
sir.
we started in 80s with a derotation plate, then interlock nail came.
Yes, sir.
But my observation is if you don't lock and only derotation plate is there, the nail may migrate up or down
Yes.
in some patients. So always lock it. Yes.
Because simultaneously, all those post groups will certainly help in early weight bearing because they will be sharing
I
some weight.
totally agree with you. Totally agree with you. Thank you so much.
Thank you, sir. Now I would like to call Dr. Santapure, sir. He's, yeah, tea and coffee. We'll take a tea and coffee break, and then we'll have a next session, the next remaining session.